I hope I'm audible, visible.
Yes, sir, you are.
Yep. So should I share my screen so that my first slide is visible?
The screen share is already on, sir. We can see the slide as well.
Okay. Well, I'm not able to see the others. I'm not that savvy with this Zoom. I don't like the online meetings.
Sir, on the top side, you can see there is something called
Yeah,
a
yeah, yeah. Now I can see others. Yes.
correct, correct.
Dr. Bhavana is coming. I hope so.
I would need to check with her.
Yeah,
Just one minute,
yeah.
sir.
So we have another 2 minutes. People are joining.
Sure, sir.
When you tell
Can,
me when to start, we'll start accordingly.
can we give them a few more minutes than two? Like
Yeah, 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 of course.
start at 2:05. That's okay.
Indian Standard Time.
Exactly, sir.
Uh, Indians don't do things on time. Notorious people.
Hi, Amol.
Hi, hi, ma'am. Oh, hi, ma'am. Dr. Shona.
Yes.
Yes. Thanks for
Can you
coming.
believe I'm also attending?
No, 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 no. Thanks for joining, madam.
No.
We're not sure about Dr. Bhavna. I'm joining in. She has some competing meetings right now, I think.
Okay.
So
So
she
let me
might come
know.
in a
I
few
think
minutes.
once another 2 minutes will wait, and then whenever you want me to start, I will start.
Sure, sir, sure. Yeah.
I think your students have joined.
They are in the conference room, sir, all in one place.
Oh, we cannot see them.
Just give me a minute, sir.
Yeah, put that camera on. At least I can see some audience.
Our students are running back from the OPD, sir. Just give us a few minutes.
They're running back from the OPD. Fantastic. We will wait another 2 minutes,
Sure, sir.
and then
Thank you.
start.
Yeah.
Yep. Let me know once your students join so that we can start.
Sure, sir. My team will inform me and I'll let you know as soon as.
I think we have already past 2.
Yes, sir. We just start at 205, irrespective of.
Okay, 205.
Yes, sir.
But we'll finish at 300.
No problem, sir. That's up to you.
Yeah, no, I also have the OPD student. I'm in my clinic.
I understand, sir.
I think we should start.
Sure, sir. Please go ahead.
Yeah, so I hope my slides are visible.
Yes, sir. Perfectly
Yeah.
on show
So
please.
thanks for inviting me, Dr. Bhavna. And we are going to talk about beyond the p-value, practical statistics for Oncology Fellows. Dr. Amol Akhade, I'm senior consultant in Fortis Hospital Mumbai. And I have no conflict of interest, but of course I have a confession to make. I'm not statistician, nor good in mathematics. I'm a simple community oncologist who likes to read, think, and discuss. Aim of this talk is to help oncologists to better understand published data. Of course, I will not bore you with difficult formulas from stats. I myself don't understand them. We will discuss key concepts which will help us analyze published data better. And let us understand ultimate aim of all this discussion is to make better decisions for our patients in clinical practice. So, to start, I will like to ask if any one of you have ever read this. So these are two interesting articles, and if you see, one was published in 1993 in NEJM called as Data Torturing, and the abstract is visible here. If you torture your data long enough, they will tell you whatever you want to hear. And it is a popular observation. And I will strongly recommend you all to read the full text of this and also this BMJ editorial. This is a very famous editorial by DJ Altman, The Scandal of Poor Medical Research. This was published in 1994, 29 January. We need less research, better research, and research done for the right reasons. And as he says here, what then should we think about researchers who use the wrong techniques, either willingly or by ignorance, use the right techniques wrongly, misinterpret their results, report their results selectively, cite the literature selectively, and draw unjustified conclusions? So please have a look at these both papers whenever you have time. But the current generation, these are 1994 papers, so around 30 years back. Only thing that we read nowadays is press release. We are not bothered about any GM or Nature paper or ASCO presentation, but we are bothered about the press release, and that is what it is. And unfortunately, when oncologists read the published articles, most of them look at the p-value. They most of them end up reading abstracts, see the results, and the moment it comes to that part of statistical discussion, hazard ratios and alpha and power, then that becomes too boring for everyone to read. So, yes, we are all triggered by the p-value. We all been trained since our MD days that p-value less than 0.05 is the gospel truth. And if it is above that, then that is not something that we are looking forward to. So, everybody wants to learn statistics and everybody wants to learn it this way. Set a goal and achieve it, but please understand it is actually not an easy task to do. Statistics is not being taught in medical schools, unfortunately. And so most of our learning is by reading, by discussion, by analyzing, and sometimes it is by the self-study. So let me tell you, you cannot learn it unless you love it. So don't try to remember the formulas. We have enough softwares to do the maths. There are lots of softwares that we all can use to do the mathematics. All we need to understand is the concepts. So main aim is to pick up weak data from strong, meaningful one, because ultimately that matters as a clinicians. So in today's talk, we will talk about sample size, power, alpha allotment, hazard ratio, and if time permits, subgroups and forest plots also. So let's talk about power. You must have read quite a lot of time this line. The study is powered at 80% with two-sided alpha 0.05%. And what does it mean? So let us understand what is alpha, beta, and power. So alpha is probability of falsely declaring benefit. And that is, of course, called as type 1 error and usually set at 0.05. What is beta? Beta is the exactly opposite thing. False negative error. That is probability of missing a true treatment benefit. It is also called as type 2 error. And generally, beta of 0.20 corresponds to 80% of power. Power of a study is probability the study detects a true treatment benefit. Commonly, it is 80 to 90% in oncology phase 3 trials. So let me explain this with this simple cartoon. So basically, you had gone to a safari and you wanted to spot a tiger. And the power is when your guide says that there is 80% chance that you will be able to detect the real target. Alpha is type 1 error when you start visualizing the tiger when the tiger doesn't exist. And beta is type 2 error when there is actually a tiger and you missed it when you could have easily clicked photos with him. So basically, alpha is false alarm, beta is missed signal, and power is seeing the truth. So I hope that makes it simple, but there is something called as a two-sided alpha, 80% power. So what do you mean 80%? So 80%, that means if a true benefit exists, the study has an 80% chance of detecting it. That means 20% chance of missing it. So why generally so I will put it the other way around. That means if you are confident about your drug and you are doing a trial and you are sure that you will able to the drug is going to work for that particular condition, you keep the power 80% because you know that there is 80% chance of detecting it. What is two-sided alpha? I want you to look at this particular bell-shaped curve. All of you must have seen this. So the two-sided alpha, that means a total probability of 5% of a false positive result on either side. That means 2.5% risk of falsely declaring benefit. At the same time, 2.5% risk of falsely declaring harm. Now, do all of the trials follow that? Let us see some of them. See, it's conventional to have 80% power and two-sided alpha, but some of them nowadays you see one-sided alpha. And that means the entire alpha is allotted not to miss the benefit, and they compromise missing or letting the harm pass by. And that is the problem when you have one-sided alpha only. Ideally, it should be two-sided alpha. So now comes to a very important question, how sample size is calculated. So sample size is calculated based upon what is the alpha, then what is the power, and more importantly, what are the events that you are looking for the clinically meaningful difference that you expect? That means when you do a clinical trial, you have already a drug which is working for a particular condition. You want to show the new drug is going to work better. Then how much better you wanted to show? That means this is basically based upon how ambitious or how confident are you about the drug being tested. If you are very confident that you know that your drug is good and for that particular condition it is going to work, then you can keep the power of 80%. But if you feel you're not confident, or you feel that whatever the small benefit, I want to pick that up also, then probably you're required to keep the power more because we don't want, when you keep it 80%, there's 20% chance you will miss it. When you keep it 90%, there is only 10% chance that we'll miss it. So if you are, so it all comes to uh, how much ambitious, that's how I put it, or how much confident are you as far as the drug effect that is being tested? So in oncology, the number of events matter. All we wanted to do is we wanted to prove that this particular drug is better in the form of improving survival or reducing relapses or stopping or halting the progression of the disease. So most of our trials, it is time to event trials. So actually we wanted to understand what are the number of events that we want to be better than the control arm. So if you expect a marginal gain, that means you know this particular drug in a particular setting, because not just the drug, but the setting also matters, whether it's an adjuvant setting, whether it's a metastatic setting, whether it is a first line metastatic or a third or fourth line metastatic, and you know how much gain that you are expecting. So if you are expecting a significant gain and you feel that the drug is robust, then probably you can keep the power by 80%. But if you know that the gain is going to be a marginal gain, you know that you required a lot of events to occur to have that marginal gain to be shown, then they required a larger sample size, and that ends up being an overpowered trial. Most of the oncology trials nowadays, I will show you some examples, are overpowered, but yes, unfortunately, we can have underpowered trial also. So too few patients or events to reliably detect a true benefit effect. That means, unfortunately, the sample size is too small, there are too few events has occurred, and even though the drug is effective, but because of the trial design, the trial is underpowered, we are not able to show the effect. And sometimes this happens. It's not that common. So that is why when you see the negative trial, we'll have to see whether really the trial was powered enough to answer the question that it is asked. So the drug is not working probably because of the trial issue, or it is not working because what we called as the sample size is too small. So let us first, of course, the common thing that happens in overpowered trials, that means you know that the benefit is too small, and to find that benefit you require a lot of events, and to have a lot of events you require a lot of patients, and that is what we're trying to show in this cartoon. So I will give you a real world example. My favorite trial, ribociclib plus endocrine therapy in early breast cancer, that is the NATALEE trial. It is 85% powered. They have chosen only one-sided alpha of 0.025. That means they wanted not to miss any benefit. They are okay if they end up missing some harm. They wanted 500 events for final analysis, and hence they have to enroll lots of patients. So you have to understand that, of course, this is an adjuvant trial. So in adjuvant trials, it is very difficult to show the gain up and over the already existing therapy. So that particular thing you have to give to this particular trial. But at the same time, if your drug is robust, then probably you may not require that much power, but they have powered 85%. There's nothing wrong in doing that. There's nothing wrong in one-sided alpha only, not two-sided alpha. But when you read this, you have to keep this at the back of your mind. I'll give another example of from a different cancer, neoadjuvant chemotherapy with FOLFIRINOX and perioperative chemoradiotherapy for patients with locally advanced rectal cancer, and in which they wanted to show a 10% increase in 3-year disease-free survival. That means they wanted to show, it's very ambitious, to show from 75% to 85%, 10% jump. And they wanted to show a hazard ratio of 0.56. This is again very ambitious. And what they have done, they say that, yes, we wanted a very large difference to be shown. We cannot afford to miss any events, so let us keep the power to 90%. Good part is at least they put the two-sided significance level at 5%, but the power was kept at 90% instead of the routine 80%. So this is something about the sample size. And when you see the trial as 1,000 patients, 2,000 patients, you have to look back, check the power, check what is the alpha kept, whether it is one-sided, two-sided, and what is the disease setting, and then you'll have a fair idea. and that how much confident the trialists are about their drug. So, is it the new phenomenon? No. There are some trials with almost 95% power. That means they just don't want to miss any tiniest of the benefit. And it had some tens and thousands of patients. And these are famous trials. I hope there are oncology fellows listening to this talk. So, this is homework for you. I don't do spoon feeding for everything. So, this is homework that you have to find out an oncology trial, famous oncology trial with 95% power. And if you can find that, please put it in the chat box or you can email to me later. Now, let us understand. Move on. Now that we have decided the sample size. So, what about the alpha allocation? That means, let us understand this concept. We know what is alpha. It's a type 1 error, and we had kept a threshold 0.05 two-sided. But the trial has multiple endpoints. And when the trial has multiple endpoints, that alpha gets distributed. So that's what we're trying to show, that alpha is a limited resource that must be distributed. And if there is PFS, OS, IDFS, or CNS progression, multiple surrogate endpoints are there, unless and until you have a pre-specified strategy of how you are going to use this alpha, then unfortunately some of the endpoints may not be sufficiently powered to detect a true effect. And that is why not only how much alpha is taken is significant, what is the distribution of that alpha when you have multiple endpoints, primary as well as secondary endpoints, you have to note that. So what are the ways by which this alpha is allocated? Because now most of our trials have at least two endpoints, progression-free survival, overall survival, some have IDFS. So now there are various ways, and I will show you 2 or 3 prominent ways. One is called as hierarchical or gatekeeping alpha strategy. So what it means, that full alpha, that is 0.05, passes forward only if the prior endpoint is significant. That means the trialists say that if the PFS comes positive, then only we will pass on the alpha to the OS. So if the PFS, unfortunately, the trial is negative for PFS, not showing benefit of PFS, we will not move forward and probably will not analyze the OS. And if the OS is positive, then only we'll go to the other secondary endpoints about CNS progression or distant treatment-free relapse or any other secondary endpoints they want to take. So if the first endpoint fails, all the downstream tests becomes descriptive. That means whatever the analysis they have put in the paper, if the first endpoint has failed and there is no alpha allocated to the subsequent endpoints, then even though they are numerically better or not, they are only descriptive. We cannot have a conclusion out of them. It is the most common strategy used in oncology phase 3 trials, and I'll give you a recent example. This is Horizon Gala trial in ASCO GI 2026. The zanidatamab, the new drug, anti-HER2 drug, and combination with the immunotherapy drug, the tislelizumab with chemotherapy, and this was in recurrent metastatic, locally advanced, unresectable gastroesophageal adenocarcinoma, HER2 positive. So when you have these presentations, they always show these kind of nice slides, which most of us pass on. But look at the alpha allocation strategy that they have done. What they are shown here is that they will first check the PFS of the triplet versus doublet. Then they will go to the PFS of Zani plus chemo versus Tras2 plus chemo. Tras2 plus chemo is the control arm. The Zani plus IO plus chemo is one of the trial arms. Zani plus chemo is another trial arm. So first they will check triplet versus doublet PFS. If that is okay, then they will check the doublet versus doublet PFS. If it is okay, then it will go to the OS of, again, the triplet versus doublet, then the OS of doublet versus doublet, and then the last OS. So this is the hierarchical or fixed sequence gatekeeping alpha strategy. The single overall alpha is allotted in a systematic manner. The next endpoint is tested only if the previous one is significant. And if the one test fails, that means if the first one, the PFS fails, then unfortunately all the subsequents will be only descriptive. And that is where sometimes there is advantage. I will show you an example in subsequently that how sometimes it can be disadvantage also. But this is generally considered as a honest, robust strategy that the trialists are confident that their drug will pass on this sequential test of PFS of doublet versus triplet, and then they will check the subsequent PFS and OS. So this shows that the trialists are confident about their drug, about their strategy, and that is generally something which is followed in most of the oncology trials. But not all trials are like this. There's something called alpha splitting and weighted allocation. So here you saw there is no splitting of the alpha. The entire alpha of 0.05 went from one PFS to another PFS to the OS if it is positive. Here, upfront, they have divided the PFS into 0.03, that was the alpha, into 0.03 for PFS and 0.02 for the OS. And this is a weighted allocation, prioritize more important endpoints. So how they decide whether give to 0.03 to PFS and 0.02 to the OS is again the judgment of the trialist. That judgment comes from, of course, if it is a phase 3 trial, it comes from the phase 2 data. Or if it is if there is any real world experience, it comes from that. Or what is the biological rationale? So based upon that, and sometimes or most of the times, all the trials are done for FDA approval. So they know based upon the setting that even if we get a PFS gain, we will get the FDA approval. Or sometimes that is adjuvant trials where OS will take a long time. So they want the PFS to come first, and the PFS is more priority, especially for the approvals. So based upon this, lot of factors, the trialists decide how much allocation should be to the PFS and how much to the OS. And that is the problem because sometimes it reduces power for each individual endpoints. And there is something called as another fascinating thing called as an alpha recycling. That means once you have allotted an alpha to a PFS and the PFS is positive, then the alpha passes on, 0.03 is passed on to the OS analysis. And it is more powerful and efficient. That means you are testing in a sequential manner, but the same, you have split the alpha, but you are not wasting it. That means the subsequent endpoints are not having less alpha. They carry forward the alpha of the previous one. And I will show you by the example. The problem here is that it's very complex and it requires pre-specification, and a lot of regulatory trials use it. So let me give an example. So this is the famous Atezo plus nab-paclitaxel trial in advanced triple-negative breast cancer, NEJM publication 2018. And I have taken this particular figure from the statistical analysis which is published in the appendix. And I want you to carefully look at this. Read the signals put here. One is alpha split. So alpha 0.05, it's got split first into 0.01, 0.04. Then the 0.01 further got split for the PFS in intended to population and PFS in PDL1 population. So 0.01 becomes 0.005. Then comes what is called as hierarchical testing. That means overall response in intent to treat. And what they have nicely shown here is that all the arrows are going back. The 3 means alpha resampling or recycling. That means everything is going back when you are having a later on OS analysis. And they have given the time period also, approximately 30 months for the first analysis of the PFS and the 53 months for the OS analysis. So what is they're doing is that they are probably smart enough to understand that we cannot weaken our OS also. At the same time, we want the PFS also. And once we get the PFS, we will pass on the alpha to the subsequently for the OS analysis. So the OS analysis doesn't end up becoming completely underpowered. The OS analysis also has hierarchy. If you see, first in intended population, if it is come positive, then it will go to the PDL1 positive. That means they, of course, are thinking that let us first show that the drug works in all population, and then we will try to show that it was also in PDL1 positive population, because ultimately, of course, for approval purpose, if it is working in all comers, it is beneficial for the pharmaceutical companies. So sometimes that may be the thinking behind this. But what I'm trying to suggest is that these things are published, they are pre-specified, and they are there in the most of the time in the supplementary appendix, which quite a lot of us do read. So next time when you started looking at the trial presentation, trial slides, look at the statistical analysis slide, look at from the appendix, the publication, the full paper publication from the appendix of that, look at what was the alpha splitting. And once you start reading it, probably will start enjoying it more. So this was a hybrid alpha control strategy, as we explained. Again, the downstream endpoints cannot be claimed if upstream test fails. So when you look at this and then suppose the OS is positive only in intended population with this particular alpha, not 0.05. You remember that it's come to 0.04. So your p-value has to be according. And then only you have to say that it can be tested or it is positive or not in a PDL1 population. So these are finer granular points. And if you are understanding of how that is being done, and it is generally disclosed, all good publications disclose this. So then you can have better understanding whether what data that is being shown and what data that is being projected as a significant data is really statistically significant or not. So how sometimes this backfires? This is very classic examples, and I like it very much. This is the Skyscraper 01, phase 3 randomized trial, double-blind placebo-controlled study presented in AACR 2025. And this is about the newer drug, that is tiragolumab plus atezo versus placebo plus atezo. So this is TIGIT. And you all know that after immunotherapy, the latest drugs that people are trying, apart from ADCs, are anti-TIGIT drugs. So the tyro plus atezo versus placebo atezo. So now I'll show you the graphs. If this is the PFS graph, and if you see here, I think it is visible that the hazard ratio is 0.78 and p-value is 0.02. 0.02, much lesser than 0.05. Yes, the PFS is at least prima facie. If somebody look at this, will say the PFS is positive and the trial should be considered positive for PFS. Numerically also reasonable difference, 7 months versus 5.6 months in the medians. Unfortunately, if you see the OS, the p-value is 0.22, which is obviously everybody knows is a negative for the OS analysis, and the hazard ratio is 0.87. So if you look at only these two slides, you will say that yes, the trial should have positive PFS because the p-value is 0.02 and negative for OS because p-value is 0.22. But has it happened like that? Unfortunately, no. And the answer is in the way in which the alpha was distributed. So what error that they did is that they have the alpha of 0.05. They allotted only 0.001 to the PFS. And the rest all was put for OS. So they were, I don't know what they were thinking. They were confident that the drug will definitely show PFS benefit. It's all that is important to show the OS benefit. So let us allocate the maximum alpha to the OS. Out of 0.05, 0.049 was allotted to the OS and only 0.001 was given to PFS. And that is why what you see that the OS could not be rescued by the strong PFS signal. There was no recycling also. So if you see here, the p-value of 0.02, unfortunately, it was required to be much lesser than that because that was the alpha allotted. And hence, I say that if they would have kept a better alpha splitting strategy, given more alpha, maybe 0.01 alpha to the PFS, They would have claimed positive PFS, and maybe they could have claimed for an approval, at least for based upon PFS from the US FDA. I don't know whether FDA would have given that or not, but at least they could have claimed. But here, what happened, even though these are reasonably good curves, splitting reasonably well, and the p-value is 0.02, because the alpha that was located was 0.001, they could not claim the PFS benefit to be positive. And unfortunately, because of that, the entire trial was labeled as negative trial. And that is why I always say the drug is as good or as bad as trial design. And this plays a very important role. Now, if your drug is as good as a blockbuster drug like Tazobactam, it's a blockbuster drug, it works fantastically, or for example, tucatinib, it works fantastically, then you don't have to do all these things. But if the drug is not that great, then you cannot make such blunders of putting an alpha of 0.001 to the PFS. And then, unfortunately, even if you have a reasonably good numerical benefit with a p-value of 0.02, unfortunately, it has to be labeled as negative, and then you will not go for the regulatory bodies for approvals. So this is something which is interesting, and I think this is something that we should start reading, start looking, and if you start doing it more often, then probably you will start enjoying such kind of granularity in more depth. Now, moving on, what is called as interim analysis. Now, interim analysis is a pre-planned analysis conducted before the trial completion. Generally, it is a pre-planned, and it looks at accumulating data while the trial is ongoing. Usually assessed by independent data safety monitoring board. It has to be like that. There's no point in you are a trialist and you are only looking at your data. No, it has to be done by an independent body, data safety monitoring board. Sometimes it can lead to early stopping if they feel that the trial is causing harm. Sometimes it leads to some modification in the data. Sometimes because of the new data has come up, the trial can have some modifications. But all these things needs to be clearly specified in the protocol. And after some modifications are done later, then that needs to be mentioned in the final publication. Now, let us understand why it is done. We all know that we do not want to have continuation of ineffective trials, safety monitoring for unexpected toxicity, and assessment of futility. That means if at interim analysis you find that no, it is not working, there is no point in putting your resources and patients for that particular trial for another few years. So it is commonly done in large, long duration oncology trials, and that is something that we look at. But there is some important risk here. What is the risk? It is like if you keep on looking, suppose you have a box of chocolate. Somebody's given a box of chocolate, and I told you that you have to, there are some 20 chocolates. And if you have to open it at the end of, say, 2 days, but after every 2 hours, you keep on opening it, then every time you get tempted, I will eat something, I'll eat something. And then you keep on doing that. And then by the end of 2 hours, you feel that there are very less chocolate left, and then there is a problem. So this is what happens. I wanted to look at this graph on the right side. What it shows that how each look at data can increase the error interpretation. At every look, you are spending the alpha. That means if you look at once, if you look at twice, if you look at thrice, if you look at 5 times, if you look at 10 times, the way the cumulative type 1 error is going to go up and the alpha is going to get weak, and such multiple interim analysis, whatever data that comes, may be numerically okay, but statistical power has gone down, and such data needs to be taken with pinch of salts. So it is very important that the effect size may be exaggerated when the trial stop early, results may appear stronger than long-term reality. So now alpha spending needs to be done in a proper way. That is, of course, because interim analysis is required. Of course, nobody does these many interim analysis. The way it is shown here, generally it is done 5 times, 6 times maximum, or sometimes only 2 or 3 times as a pre-specified thing. If you see the famous keynote trial for triple negative for pembrolizumab, they have almost, I think, keynote 522, they have almost 6, 7 interim analysis till the time the OS was declared, but most of them were pre-specified and alpha was allocated. So how this alpha is allocated, there are two ways of doing that. One is O'Brien-Fleming alpha spending method, in which what they do is for the early interim analysis, they keep very low alpha. That means 0.005, later 0.01. So final analysis, you at least have reasonable number of alpha remaining. Why this is done? Because in early interim, if you find that the drug is toxic or there are too many side effects, then you can stop it early. But if it is not, then you have not spent too much alpha in the beginning. And for the final analysis, we have sufficient alpha remaining. And that is what is being done in the keynote 522 also. And a lot of trials do that. They do interim analysis, especially in adjuvant trials. See, like breast cancer adjuvant trials, you cannot, the OS will come after 5 years, 7 years. So you have to have an interim analysis. You have to open the chocolate box and see what is happening inside and how things are going. And then you have to make sure that you don't spend too much alpha by the time you reach 5 years, 6, or the fourth or fifth interim analysis. And that is why this O'Brien-Fleming alpha spending is followed more or less universally for most of the oncology trials, but there is something else also that is called as Pocock style, and in which for all interim analysis, they keep the exactly same alpha. Now, the good part of this is that you are not going to miss out any harm because your alpha is strong, 0.022. But the bad part is that for final analysis, again, your alpha is 0.022. And that is why for the final analysis, you need to have more stringent p-value than the conventional 0.005 because your alpha has come down to 0.022 because you have spent it on the interim analysis 1 and 2. And the classical example is a solo 1 trial in ovarian cancer, olaparib adjuvant. The olaparib adjuvant, if you see that graph, I have not put it here, but if you see the graph, the p-value is in 0.00. It is much less than 0.05, but still the OS is labeled as numerically good, but not statistically good, because unfortunately they have spent a lot of alpha beforehand only, and they do not have sufficient alpha in the end. So when you read solo 1 trial, go through that and you'll understand that. So to conclude at least the first part, that is the power. What is the checklist? This is, I have listed some points which I want all the fellows to note. So the power, was the trial capable of answering the question? Was the primary endpoint clearly defined? Whether the co-primary dual, all those things is clearly defined, where all are given some power, if not all, or should not have only one is powered. Please know the famous trial of, I think, the Destiny Breast 11. The trial is not powered for OS. If you see Adura, the osimertinib trial in non-small cell lung cancer, not powered for OS. So this is a red flag. And that is why the primary endpoint should be defined and should be sufficiently powered. The target effect size should be stated. That means how much they have assumed the hazard ratio will be, the assumptions, whether it is clinically meaningful or optimistic, what is the power level specified, whether it is an event-driven sample size, whether it is observed number of events when they do analysis is close to planned events, or it is much lesser or much higher. Was the trial stopped early? If the trial has stopped early, then what was the reason? Was the early stoppage due to inflation of the effect size? And if the trial is negative, whether it is simply negative because underpowered. So all this checklist should be done when you read the statistical analysis part of a published trial. And for alpha, you have to first see whether it is one-sided alpha or two-sided alpha. Actually start seeing that oncology gold standard is two-sided alpha, but you'll be surprised a lot of new trials have one-sided alpha. That means they do not want to miss any benefit, but they are ready to ignore some harm, which is ideally is not good. Now, whether the alpha, how the alpha splitting is done, how alpha is allocated to all these endpoints, this needs to be checked. And if there are multiple positive endpoints claimed without clear alpha control, then unfortunately, that is a red flag. And you have to understand that they should accept that this is only descriptive or numerically good data, but not statistically good data. So this is a checklist, and I hope this will help you to understand. Moving on. Now, ways to evaluate results of a clinical trial. There are 10 ways: hazard ratios, median PFS, median OS, relative risk, absolute risk reductions, number needed to treat, time point survival rates, restricted mean survival time, landmark analysis, subgroup and interaction analysis, and of course, quality of life and toxicity concerns. So there are close to 10 ways by which a data is to be assessed. And today we will talk, of course, we are 2:45. We'll talk about the hazard ratios and if time available subgroup analysis. So hazard ratios. Again, I will show you a nice paper, again in British Medical Journal. BMJ and once upon a time NEJM used to have lovely papers. And this is again in 2011, it's not that old. Might BMJ lead crusade against reporting only relative risks? And the gentleman has criticized about the way most of the trials they talk about relative risk but not the absolute risk. And I want the trainees to go through this, and it is available on internet. Please read this. Now, what is hazard? Hazard, as the word itself suggests, that hazard is something, an event which is not good. And most of the time, that hazard is either death or a progression or a relapse when they're looking at oncology trials. And hazards can change over time during follow-up, and it applies only to patients who are still event-free. That means they're still in the trial. So what is hazard ratio? Hazard ratio compares hazards between two groups. As simple as that. Hazard in experimental and hazard in control. So whatever hazard that I've chosen, whether it is a death or a progression or a relapse, what is the hazard in experimental arm divided by hazard in control arm, and that is being tested. Of course, we required what we called as the KM curves or the survival plots, and it is done by estimate using Cox proportional hazard model. So the basic rule of thumb for oncology trials is if the hazard ratio is 1, no difference between groups. Hazard ratio less than 1, lower the hazard in numerator group. So that means the trial drug or the new drug is reducing the hazard. If it is more than 1, then unfortunately your drug is producing more hazard. How much more, that we will discuss. But this is the rule of thumb. You have to at least check whether the hazard is 1, more than 1, less than 1. Now, what does hazard ratio of 0.60 mean? It means 40% lower relative risk of the event. This is very important. Lower risk, but relative risk, not absolute risk. It is not absolute gain. So when you describe hazard ratio 0.60 to a patient, you cannot tell them that you will live 40% longer or you will survival improve by 40% or your chance of cure is 40% higher. These are statistically incorrect and misleading things. It is better not to talk about hazard ratio to the patients and better to talk about the absolute survival gain. That means the absolute risk reduction that should be chosen and that should be spoken, and I will show you in the examples. What is important is the hazard ratios also have confidence interval. What it means that suppose the hazard ratio is 0.60 and it has a confidence interval ranging from 0.4 to 0.9. What it means that this 40% reduction has this particular range that if you repeat this example or trial multiple times, every time the risk reduction will be between this particular range. And the moment that confidence interval crosses 1, that means you have a problem. At least in certain times, not all time, but certain times, the drug is going to cause more harm than the benefit. And that is why the confidence interval, along with the p-value for that confidence interval, also needs to be checked. And what is important is that you cannot interpret hazard ratio without looking at the KM curve shapes. Because please understand, the hazard ratio is based upon this principle of Cox proportional hazard. That means the hazard remains proportional over the entire duration of the trial period. That means that the curves are pretty well separated, or they are not crossing to each other, or what we generally call they are not kissing to each other. So hazard ratio alone is of 0 value. It has to be interpreted with the shape of the KM curves. It has to be interpreted with the confidence interval. It has to be interpreted especially for the subgroups with the p-value for that subgroup. So let us take this example. Again, the same favorite trial of mine in which ribociclib plus AI versus AI alone. Now, if you see They are saying the hazard ratio for invasive disease recurrence or death is 0.75. That means 25% relative risk reduction, or one can say that. But if you see here, what is the absolute reduction? 90.4 minus 87.1 comes to around 3%. So the absolute benefit versus the relative risk reduction, they are two different things. And that is why when you're looking at the hazard ratios, you have to, of course, look at that number. That is important. Lesser the hazard ratios, better it is. But in isolation is of no meaning. You have to see the KM curves. Are they separating pretty early? Answer is no. They are separating almost at the end of 2.5 years. Is the absolute benefit great? Yes, some may say it is okay, 3.5%. But all these things, at least the good part is that the confidence interval is 0.60 to 0.91. It is close to 1, but not crossing 1. And it is a two-sided p-value. Again, that is good. And of course, this is based upon whatever alpha they are allocated, but it's significant. Now, this is another curve, another favorite drug of mine, Lorla versus crizotinib. Now, look at these curves, well separated. Look at the hazard ratio, 0.28. Look at the confidence intervals, 0.19, 0.41. So if you take this, look at the p-value. Of course, unfortunately, again, is one-sided. Ideally, could have taken two-sided. But if you look at this curve versus this curve, you will appreciate that, of course, this particular drug is in this particular condition against this particular control arm is doing much better as compared to this drug in this condition against this particular control arm. So point here is that the hazard ratios cannot be taken as one isolated number. You have to see the confidence interval, you have to see the KM curves, and then move on. Now, what is this principle of proportional hazard? The PH, or principle of proportional hazard, assumes the hazard ratio remains constant over time. And how can you see that? By visual check, you can yourself see that the curves are only close till 3 months and then they are widely separating, versus here, the curves are close almost to 2 years, 2.5 years, and then they are separating later. Now, non-proportional hazards, that means the treatment effect changes over time and the curves cross to each other. It is common in immunotherapy trials, certain maintenance trials, but it violates the proportional hazard assumption of the Cox model. And this is the classic example, STRIDE. This is the HCC trial of durvalumab versus durvalumab versus sorafenib. And if you see here, up to first 12 months, you cannot even make out which curve is crossing to whom, unless you come to this particular part where the curves are well separated and we can make out, oh, the stride is on the top. Otherwise, here it is like a wrestling. You don't even know who is at the top or who is at the bottom, who is in the middle. So these are the curves where you have to understand that the Cox proportional hazard principle is violated and you have to ideally do something else. And that something else is restricted mean survival time, which basically means the area under the curve before the curves cross, area under the curve after the curves cross. And of course, we'll discuss at some other meeting or discuss lecture about this. But these are the methods. Restricted RMST, a lot of journals, they start giving the RMST values, at least for some of the publications. These are other methods, piecewise or time-dependent HRs or weighted long-rank test. We will discuss that in the subsequent class. But I want you to understand this, that when the curves cross, the interpretation of the hazard ratio is to be taken with a pinch of salt. Now, moving on, what is median PFS or OS? Median is a time when 50% events have occurred. This is a very simple, straightforward definition and represents only 1 point on the KM curves. That means it is not going to tell you what happened afterwards. It ignores long-term survivors and the tail of the curve phenomena. So hazard ratio and median PFS OS, they don't go hand in hand. Median PFS reflects only 1 point of time. The hazard ratio summarizes the entire survival experience. The large hazard ratio may have a small median gain. I will show you example. And the same median can arise from different hazard ratios. So this sometimes the median may mislead. And let us have this example. The p-value is less than 0.001. PFS of both the curves is 5.6. So what is happening? If you look at the median PFS, if you see here, it is 5.6 and 5.6 for both belzutifan as well as everolimus. But the p-value is 0.001 and hazard ratio is reasonably okay, 0.75. Why this has happened? Why this is happening? Because unfortunately, I think, yeah. So why this is happening is because the curves diverge later on. That means if you look at only the median, you will say, no, 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 the belzutifan is not working as compared to the everolimus. But the curves diverge later on, and that is something that the median don't take into consideration, but the hazard ratio will take into consideration. Another classic example of the Nivo plus Gemcis versus Gemcis in the advanced urothelial bladder carcinoma trial. If you see the median PFS benefit is hardly 9 days. If you see here, 7.9 versus 7.6, hardly 9 days difference. But the p-value is significant for the hazard ratio, 0.72, because after the median is somewhere here. After that, the curves are well separated, and that is why the p-value is for the hazard ratio, because the hazard ratio will see the entire journey. It will not stop at the median. Median will see only at one point. So quite a lot of us get stuck at the median. It should not happen, especially in the immunotherapy drugs or certain targeted drugs. You can have a delayed benefits, and that is where the hazard ratio can be still good. And this is very important to understand what is called the tail of the curve phenomena. And it is important for the immunotherapy drugs. But what is also important is what you should see, that the numbers at risk, and you must check that. What is the number of risk? Now, this is your TOPAZ trial. Now, the TOPAZ trial also, if you see here, there are numbers of risk given. And if the numbers, when these particular tails are separating, say at 36 months, how does the numbers start at 341, 344? What is the number here? 43 and 18. If they're less than 10% or lesser than that, then you have to take these results with pinch of salt. Yes, there is a delayed benefit. Yes, some of the patients are going to do well, but this particular point analysis, which has been shown here, 36 months OS and 24 months OS, this is of no use if the numbers which are at risk at the bottom are not sufficient enough. And there is no rule of thumb that how much it should be, but general consensus is that if they're less than 10 to 15% of what we started with, then we have to take those results with pinch of salt. We will still tell that yes, the drug is working in certain patients, the drug is showing benefit in certain long-term responders. We of course don't know who they are, but whether there are statistical benefit, that is very difficult to say, because the numbers at the risk at that particular point of time are very less. Now, I think we're coming to fag end. What is a good hazard ratio? And this is something, I'm not an alcoholic person, I don't drink, but this is something that I like to put. A hazard ratio more than 0.8, but benefit, absolute benefit less than 5%. Okay. Hazard ratio between 0.5 to 0.8 and an absolute benefit of 5 to 10%. Great. And the best is hazard ratio less than 0.5 and absolute benefit more than 10%. Again, when you look at the hazard ratio, do not see in isolation, see the absolute risk reduction, shape of the KM curves, performance of the control arm, the disease setting, the bad disease, good hazard ratio, good absolute risk reduction, that's the jackpot. Good disease, okay hazard ratio, not so much absolute risk reduction the way Natalie has shown. It's okay. It's not great. So that is how you have to understand. It's not on one number. You have to look at everything. Look at the KM curves. You look at what is the absolute benefit, what is the disease setting, what is the performance of the control arm. A lot of things you have to see when you say that, oh, this trial's hazard ratio is good. So this is the checklist. We have already covered this. The width of the confidence interval has to be checked. Whether the confidence interval crossing 1 has to be checked. Proportional hazard assumption has to be checked. And of course, the clinical relevance is also important. Now, do we have another 5 minutes? Should we still complete I have some more slides, or should we keep for the later part? The subgroup analysis?
Sir, it's completely your call, sir. we are okay with both.
So we were looking at 3 o'clock. So I don't think so we were able to complete all those things. So I think we will do it for the latter part, the subgroup analysis. So for fellows, please read yourself statistical analysis part of published papers, discussed among your peers, take, take help from your teachers, take help from internet, take help from the Twitter, LinkedIn, YouTube, so many resources. If you still can't get an answer, you can email to me. Remember, if you want to learn anything, there is no spoon feeding. Self-help is the best help. All this is of no use if you cannot apply for betterment of your patients. The stats can tell you the data is good or not so good. That's it. Ultimately, it is your own clinical judgment and patient's wish that matters the most. For some patient, the absolute survival gain of 1%, 2% is also significant. For some patient, the 10% also may not be significant. So ultimately, it is your own clinical judgment and the patient wish that matters when you're applying that data to the clinical practice. The statistics will only tell you the data is good or bad, or it is very good or only good or very bad. Ultimately, the utilization of the data in the clinical practice, that what makes the difference between the statisticians and clinicians. And probably we'll have the part 2 somewhere. I put the 19th March because that is probably, anybody knows why 19th March? That is the date when Dhurandhar part 2 is releasing. So probably we'll also have our part 2 at that time. Anyways, thank you. So you can follow me in any of the social medias, and I think we're at 3 o'clock. We have to stop. I'm also in the OPD, so I have to see my patients. Any questions from any side? Probably we can take them on an email or something. So the subgroup analysis part we will probably do the next time. Thank you very much. Anybody has any questions or comments? We can take quickly 1 or 2 things if somebody wants to ask. Otherwise, we will wind up. So I don't think there are any questions. At least I cannot see. Or let me stop sharing my slide. Stop sharing.
There's no question in the comment box right now, sir.
Okay, fantastic. So hopefully either it is bouncer for everybody or maybe they will digest it and get back later. So thank
Correct.
you, everybody. Probably we'll have the second part. The subgroup analysis part we will cover in the second part, and some of the other things like censoring and other points we will do in the second part. So thank you very much.
Dr. Bhavna ma'am could not join today, so she sends her regards and thanks.
Thank you.
Thank you very
Thank
much
you.
for attending this
Thank you.
lecture.
Thank you.
Thank you,
And
everyone.
I hope you will send me the recording by tomorrow.
Absolutely, sir. Once
Thank you.
immediately I'll
Yeah,
send.
yeah. Thank you. Bye. Take care.
Thank you so much, sir. Have a good day. Bye.
Bye.
Can you close the meeting, Rizwana?